Hi everyone, we're going to get started with the introductory lecture for this course. What we're going to try to do this semester or mini-mester is really have all of the content be online so that we can spend more time in class having discussion, going through scenarios, and then also completing labs. Now, just to get everything on the table, this course has gone through many different iterations, and I'm trying something even newer this year. We have to accomplish two goals. We have to talk about the science behind exercise and what are the expected outcomes, as well as the practical applications of exercise. So this is why I'm going to try to get some of the science and information to you in this delivery format, and we can spend more time doing the practical applications together. What will be a bit of a challenge is that you haven't had any practice management courses. You haven't had orthopedics, you haven't had neuro rehab. So I'm going to push you outside of your comfort zone, and we're just going to, roll with it and try to do and learn different techniques to use for exercises on pathologies that you haven't yet had to study. So, but you have the anatomy and you had foundations, so it should make sense. But this is a new approach we're taking to the class. So in effect, you're my guinea pigs for this semester. So with this lecture, we're just going to talk about a few concepts, and we will bring these up in class on Monday. So just thinking about what actually is therapeutic exercise. So essentially, it doesn't have to be, only in an outpatient orthopedic setting. We will have all of our patients exercise in some way, form, or fashion, no matter what setting we are in. If you think about a patient who has COPD, and you will be teaching them respiratory exercises. So definition-wise, basically, it's therapeutic. It's supposed to help reverse or even prevent different impairments that your patients have, and also help them to restore what they were from a functional perspective and optimize health. So just take a moment and think about to yourself, what are all the different types of therapeutic exercise? And like I said, we will be picking up on this on Monday. So I'm giving you a little prompt to think about before you come in, as well as what are some of the benefits that you already know of that accompany therapeutic exercise. I want to look at a picture that this is from a motor control, motor learning perspective, and it puts movement at the center as the little M of these three circles, right? So this is a Venn diagram, so they all have overlap. So when you think about how somebody moves, and that's one of our goals as physical therapists, the word physical is in our job, is we want to get people moving. A few things are, it depends on the individual. So you look at the eye. Does the person have everything that they need in order to move? Do they have muscle strength? Do they have range of motion, right? These are concepts you are familiar with. But then we also have to think about the task. What is the task that we are asking them to do? Do they have the actual cognition or coordination to be able to accomplish the task? How can I, as the physical therapist, make the task easier? Or if this is a high-level sports athlete, how can I make the task harder so that they're going to be ready to go back on the field? Right? So the task also will have an influence over your movement. Okay? Lastly, the environment. The environment plays a huge role on what the individual brings to the table and what the actual task you are actually requiring them to do. So if you think about someone who does have to go back to high-level playing on a field, you want to manipulate the environment so that it mimics the environment in which they have to play. So there needs to be distractibility, there needs to be ambient noise, there needs to be different surfaces, there needs to be multiple players, things like that. Same thing you could also say on the flip side, if you have a person who's been brain injured, you have to really control the environment. So take away distractibility, take away outside noise. Sometimes you remove light. All right. So all of these three things are aspects that we need to really consider as physical therapists in order to enhance and optimize movement. Looking at actual motor control, motor learning, we can then take what we had as that movement paradigm in the middle Okay, so we were here on the previous slide, just looking at movement. And then we can look at some additional factors that will influence the task, the individual, and the environment. So if we start with the individual, we need to think about what is that individual's cognitive level? What's the action that we're asking them to undertake? And then what is their perception of it? We will have some people who do not believe a task is worth doing, so they don't have buy-in, so then they won't actually do it. Or we could be talking about perception such as depth perception. So if a person has had a stroke and they can't judge exactly where an object is in front of them, that is going to severely impact how that individual is going to be able to move. If we look at the task, we want to think about how can we keep this person to be able to accomplish this task by either making the task easier or making the task harder. So a few of the things that we often do, and this is a big part of motor control, motor learning, is we have to gain mobility before we can gain stability. So we need to make sure all the joints move before we can actually get stability. Okay. What we then put on top of stability is controlled movements or manipulation. So we then will say, okay, this person has enough, range of motion in their trunk to then actually maintain a stable seated position. And then we can give them something that they actually have to manipulate with their hands and see if they can maintain that seated position. Okay. Same kind of thing that you do if you think about when you go to a core stability class, they will, obviously you have to make sure that you have enough range of motion in your glenohumeral joint and in your hip and knee joints if you want to get into a plank, okay, or into quadruped if we're taking the knee into consideration. And then we need to make sure that you have enough stability, so you have enough strength in your abdominal wall as well as your erector spinae to maintain that position. And then if we want to make it harder, we can do things like we can have you manipulate. We can have you lift one leg off the ground. We can have you lift one arm off the ground. And then lastly, what we can do about the environment is it can be a regulatory environment, which every single thing is controlled by the PT. Like I was talking about, remove the lighting, remove any unstable surfaces, versus non-regulatory, where you're putting them into sensory overload, but that may be the environment that they need to go back to. One of the things that we also want to look at, and we're going to have a speaker come in and talk about movement as an assessment tool, is we need to not only be able to prescribe exercise, we need to be able to know how to do the exercise, and we need to be able to observe. So you guys went through a posture eval, you went through gait evals. Physical therapists are experts in observation. So when we're talking about therapeutic exercise, we need to prescribe it specifically. Can the patient complete the task? I don't want to give someone a push-up on the floor if I know that they are below a 3 for their triceps, okay? Then I want to look at, if the patient can complete the task, how do they complete the task? Are they moving typically or is it atypical? What is going on? Why does the movement look atypical to me? Is it because they have a brain injury and it's their patterning? Do they have a cerebellar problem? So the movement is jerky and uncoordinated. Do they not have the motor control, motor learning, or, you want to think about it, the ability to not co-fire? So some people, you take them to the weight room and they try to pick up a weight and they don't really know what to do with it. So they're firing agonist, antagonist at the exact same time. So that makes it difficult for them to figure out exactly how their arm's supposed to be moving in space. And then thinking, what is it that we can modify? How can I make this easier? It might just be putting a mirror in front of the person, or putting my hands on the person, or giving the right cues, right? You don't want to have somebody do a plank if their butt is all the way up in the air. What's that doing? That's doing nothing. But so some of the feedback that we hear is when students from Marymount go into the clinic, they need to know more about not only what are appropriate exercises to choose, but when to see if a patient is cheating, okay, or substituting. So we're going to work on that this semester. Shirley Sarman has a great model, and now physical therapy is trying to adapt the movement system, just like there's every other system in the body, the cardiovascular system, respiratory system, integumentary system, and we're trying to say that we are experts in the movement system. This is a new idea that's coming out in physical therapy. There's several articles on it. I think you guys read one of these in the first year as one of the common articles, but not everybody is on board with this yet, but I just wanted to bring you into where the development of this system came from. So what Dr. Sarman really is looking at is that she's looking at activity. So this is her therapeutic exercise model. So with the activity that you do, you have to have some movement, the mode, what is the type of activity that you're doing, and then you have to have some sort of certain posture in order to be able to accomplish that activity. Then we have, how are we prescribing exercise? So what's the dosage? So what kind of contraction do we want the person to do? Eccentric, concentric, isometric, isokinetic, all right, isotonic. What intensity do we want them to do the exercise at? Uphill, 6 miles per hour, all right, all those different things. Speed, duration, 30 minutes, 3 sets of 10, right? How long do we want them to be able to do it for? Frequency, how many times a day? How many times a week? Sequence, in what order do we want them to do these exercises? Environment, what's the environment that we want them to do these exercises in? Do we want them to do it on a smooth hallway surface, or we want them on grass, if we're talking about gait, for example? And then what's the feedback? How much feedback are we going to give them as a PT? Right? Are we going to be telling them, no, you actually need to move your foot a little bit further to the right? That will help with your balance. Do we put a mirror in front of them? Okay, all different types of feedback. And then lastly, there's different elements of our actual movement system. So if we don't have all of these elements, it's going to impact what we can actually prescribe from a therapeutic exercise perspective. So a person's cognitive or affective component, that's huge. If the person doesn't have the cognition, they might not be able to understand what you're asking them to do from a task perspective. The biomechanics, do they have the actual joint ranges of motion? Do they have the accessory motions that they need in order to accomplish this task? If we now look at some of the other items that she has, the terminology might look unfamiliar. So the base that she has listed there, second from the top, the base system is the musculoskeletal system. So that's the basis by which all movement occurs. The modulator is the nervous system. So the nervous system obviously has to modulate and give input into the musculoskeletal system in order to enable us to move. And then the support system are things that keep our body alive. So the cardiovascular system, respiratory system, even the integumentary system. So, metabolic systems, all of those things help to support us in order to be able to move. So this is just her framework of looking at movement from this systems-wide perspective. We will be talking a lot about this, and you will also hear this again when you get into neuro rehab with Julie. So this is stages of movement control. So again, we need to have mobility, and that's talking about from a joint perspective. If you are unable to move the joints and get yourselves into certain ranges of motions, then you can't have any sort of stability. If you are completely rigid, you won't then have any stability for the muscles to be able to control and allow you to hold a stable position. So first we work on mobility, and this is actually how we work with patients a lot of times. We'll try to work on things like their range of motion first before we then work on their strength. Okay, because if you strengthen a muscle without getting the range first, what's the point of that? Then we get to stability. So that usually is things like balance control, gross strength, being able to hold a static position. Then we get a controlled mobility. You wouldn't be able to get mobility on a stable base of support unless you worked on the base of support first. So then we go to controlled mobility. So that would be something like walking without, having a cerebellar injury and without having some sort of ataxia and like crazy gait, controlled mobility. And then you get into skill. So if you were going to talk about a certain joint, we would want to get, for example, hip extension, range of motion. Okay, first. Then we would want to work on standing, being able to maintain double leg stance, and then moving maybe into single leg stance, then getting into gait, then going into walking over cones. All right, so that would be like a progression for someone from perspective of movement control. When we're talking about actually making a program, so we are having a real patient in front of us and we are going to get them to exercise and we're going to design a program. You will be designing a program in every class you are in from here on out. You need to think about what are the parts that need to be in the program. All right. So number one is, how am I going to restore function? So I need to be able to look at this person, see where they're lacking, and then have an exercise program that is going to specifically address those issues. Then I need to decide what are the best activities to achieve that outcome. All right. So if I need somebody to have increased hip extensor strength, yet I can't get my patient in standing, maybe I'm going to do something in supine. Maybe I'm going to do something in side lying. Okay. Or if I have a patient who I know hates a particular activity, weight loss could be one of the elements that I'm working on. And I want them to get into a pool, but I know that they are either afraid of the water or they don't have a pool near them. That's not a great activity for me to pick for them. So think about, what's the purpose of each exercise? What is the posture that's needed? What's the equipment that's needed for every single exercise you're going to do? How much dosage should I give them? How many times a day am I going to tell them to do this? How many times a week am I going to tell them to do this? What weight am I going to tell them to lift? Then what's the sequence? Which of them do you want them to do first, second, third, last, etc.? And then progression. How am I going to progress them? You can't leave somebody with the same exercises forever. They have to be able to progress. We also have a lot of clinical decision-making going on. Which ones of the functional limitations and or related impairments are the ones that I should treat? Which ones should I treat first? Which ones are the most important? Might I be able to hit 2 for 1? How do I relate their limitations with the appropriate elements on the movement systems? How if I have somebody that has congestive heart failure, so they have a depressed ejection fraction, how is that going to impact the support system of my movement system? Maybe I need to alter the exercise somewhat. And then establishing what your priorities are. What are the most important things that you want to do first? When you are doing exercise prescription, you want to not only think about the movement system, but you need to know where this person is in time. What are you seeing right in front of you? Right? So not what you learned in school, not what you learned in the book. Respond to what you're seeing in front of you. You have to meet them where they are. You don't want to give somebody something that's really, really hard or really, really easy, because then they won't get buy-in. You want to be able to assess where they are, what the needs are, where their deficits are, and then where you need to get them to go. And you need to consider the patient's learning style. So in class, we're going to go over what's called the VARC, and we're going to figure out what each individual learning styles are, just so that you can see, there's many different ways to skin this cat, and you're responsible for every single patient that you have, working with them to highlight their best learning style. Different things that you could modify physiologically. We'll talk about all of these in a prescription. You can change the duration. You can, how many times they're actually going to complete the exercise, how often are they going to do the exercise, what is the speed in which you want them to do the exercise, what's the intensity. We already talked about different types of contractions, in what order are you going to prescribe the exercises, and then what's the appropriate amount of rest. You want to tell them, I need you to not do this, complete in a row, like I need you to take a 30-second rest between, or I need you to take a 5-minute rest between. You can determine that. You can also modify stability, external load, and the number of segments involved. So we are going to be doing this in class. I'm going to say to you, how do you make that exercise easier? How do you make that exercise harder? It's all principles of physics. You can take anything and make it harder, and it doesn't have to be rocket science. And this is one of the things that I want to try to get you to gain confidence with, is if you just learn a couple of little techniques, you can make something harder instantly. All right. We're going to do a bridge as an example in class. So you're going to do a bridge. How would you make that bridge harder? Okay. How would you change your base support? How would you change the number of segments that are involved? How would you change your support service? How would you change the speed of which you're doing things? You guys learned in foundations with your lever arm, get closer to the patient. Okay. Or if you're small and you're trying to resist a patient with hip extension, you get on the benefit of that lever arm, so you apply resistance at their ankle. It's harder for them, but easier for you as a physical therapist if you need to offer them resistance and there's a size mismatch. Same kind of thing here. How far away do they hold the weight, right? How much tension do you put on the TheraBand? So we'll practice all of those things real time in class. Other things you can do is the length of the muscle. So do you have them do exercises in mid-range? Do you have them do it at end range? OKC, open kinetic chain, versus CKC, closed kinetic chain. So open chain, knee extensions versus closed chain coming up from a squat, all right? Or doing forward lunges. Stabilization. Do you allow them to have external stabilization, or do they have to stabilize from within? Do you put them on a stable surface, so you have them doing things on the floor, or do you put them on a Bosu ball and then try to have them do mini squats, so then they actually have to stabilize using their core musculature? What's the sensory input that you're giving them? Are you allowing them to concentrate on the exercise that they are doing, or are you trying to distract them at the same time? And then knowledge of performance. That's one aspect of motor learning. Do you tell them how well they did? Do you say, that squat looked really, really good? You put your butt back, your knees didn't go over your toes, or do you just say, that was not a great squat, how are you going to make it look better? What can you do? How can you change your body? Some of the shortcomings that we do see is from the PT side. You chose the wrong exercise, or you chose the wrong dosage. Either was too little, so the patient didn't see any gains, or it was too difficult for the patient, so they didn't see any gains because they weren't able to do it. The PT also could be at fault because they can't perform the exercise, so they perform it wrong, or they don't perform it at all and they just show the patient a picture, and then the patient performs it wrong. And lastly, it could be on the fault of the patient, where the prescription could be perfect and the patient just doesn't do it. So how do you work on that angle? That's your salesmanship. So when you write the prescription, there's some do's and don'ts. The real nuts and bolts behind writing a prescription are, you have to have the mode. So what do you want them to do? Okay. Do you want them to run? Do you want them to swim? Do you want them to bike? Do you want them to walk? You need volume. How many times are they doing something? Or for, how long of a time are they doing something? You need to have a frequency. How many times are they doing it per day, per week, per month? How long are they doing this exercise for in terms of weeks, right? So you want to be able to do bridges, hold for 10 seconds. I want you to do them 2 times a day, and I want you to do that exercise for 3 weeks. Then we're going to move you into single leg bridges, okay? And then, that also incorporates total time frame. One of the things that we use as a cheat for making sure we have all of the elements of the exercise prescription is using the FIT principle. And you will hear that used all over the place. So it stands for frequency, intensity, time, and type. So on the prior slide, we had type, but we used the word mode. I also call it the FIT-P principle because you need to have progression. Too often I see people that don't think about progression. They just give an exercise prescription. But we need to have our patients improve. So always try to keep in the back of your mind that you are going to need to progress them at some point. Oh, sorry, skipped ahead, skipped back. So this was just an example of using that FIT-P. So you have the mode, stationary bicycle, duration 30 minutes per day, intensity 10 miles per hour, frequency 3 times a week, and then progression after 2 weeks increase to 12 miles per hour. Okay. All right, so now we have home exercise program. I spend probably, if I have a 45-minute evaluation, I spend at least 15 minutes on the subjective. So getting the patient to tell me exactly what's going on and interviewing them. And then I probably spend equally 15 minutes on the home exercise program. Depends. If the patient's really savvy, maybe I can get away with 5 or 10, but I want them to do it right. And I want them to get the biggest bang for their buck. So you need to get buy-in. You need to tell the patient why it is that you're giving them these exercises. And I never give a patient, unless they're being discharged, more than 3 or 4 exercises, because the more exercises I give them, the less they do. So explaining the importance is huge. Then you need to give them easy to follow instructions. They're getting information overload with you. They may not have a good exercise history. They may not remember how to do what you told them. They may lose the sheet of paper that you gave them. So you need to put it in easy to follow instructions. And you need to use the learning style which they prefer. Okay? You also need to be able to do the exercise appropriately, because if you can't do it, how are you going to show them how to do it? Okay? And then you need to use equipment that is accessible to the patient. So if you want your patient to do pull-ups, I've never had a patient that I've had do pull-ups, but they may not have access to a pull-up bar. So what other exercise could I do to meet that similar objectives that would be met from actually doing pull-ups? So also getting it to fit into the patient's day will hugely help their compliance with the exercise program. Some things you can do: have a non-distracting environment. I work in an outpatient clinic. It's very, very high volume. There's about 11 therapists that work there. When I give somebody their HEP, I don't have them in the main gym because there's other people in there to look at. There's music playing. There's patients going through their exercises. So it's really hard to get them to focus. I also will demonstrate proper performance. Then I have my patient demo it back to me. Okay? I use clear and concise, both verbal and written instructions. And I will put them in the language that the patient needs them in to a certain extent. I mean, we have software that can translate to about 3 or 4 different languages. If I know how to translate it into a language, I will also try to do that. But, you know, there's certain parameters on that. Like if I have a patient that spoke Tagalog and I was like, okay, that's really not easy for me to try to translate. But when I worked in the hospital setting and we had a translator on site, I was able to get them, you know, it was very important to be able to get that information to the patient. I also put in there periods like tutorial of silence. So do you understand the exercise? They're going to nod their head and say, yeah, of course I do. I say, go ahead and do it for me and ask me any questions as you're doing it. I also only do small parts of it. I don't teach them the 3 exercises all at one time. We'll do 1 at a time, demo. Do you have it? Any questions? Then we'll do the second exercise. How do I get them to stick to it? Talk to them about what they think about exercise in the first place. Do they think it's a waste of time? Why do they think it's a waste of time? How can we get them to not think it's a waste of time? Help them to see benefits, right? The first time you're going to have these exercises, they're going to be hard and they're going to be sore. So the patient's probably not going to wind up doing them again, but you have to help them with their expectations. explaining to them why you're doing this. I'm only giving you 3 exercises because this is what I need from you, and you're going to get better, you're going to get stronger, and then we can get you back to walking. So the more you do these within reason, you're going to get back to walking. You're going to be able to go spend time with your grandchildren. All right. So you have to really put it into perspective for the patients. Also, speaking to them in a language that is not over their heads is huge. Right. So, I found myself, I was in the clinic last week and I was telling a patient, like, all right, so I'm going to have you fire your hamstrings. Most people know where hamstrings are. This person did not. So I was like, okay, the muscles on the back of your thigh. Oh, all right, great. Okay, so don't assume that your patients know what you're talking about. So you might really have to change the way that you approach how you describe things. Have your patient write it down. There's new apps. You could film yourself. The patient could film you. You could film the patient. They could keep it on their phone of how to actually do the exercise. Figure out ways they can do it inside of their day. I have a lot of patients do exercise before they get out of bed. I'm like, all right, so you were asleep, you wake up, and before you take a shower, you're already lying down, do 2 sets of bridges. Oh, okay, I can do that. All right, you have really tight pecs. So every time you get up to go to get a drink or to go to the bathroom while you're at work, do a stretch in the doorway, pec stretch. Oh, all right, I can do that too. You have to help them focus on their progress, right? So, I always also have patients, if I've seen them, they go home, they do their HEP, they come back. I start out the session by saying, how'd you feel after you saw me last time? And then I say, can you show me the exercises that I taught you how to do? That tells me right away if they're doing them at home or not. All right. And if they are doing them and they're doing great, and I say, well, great, I'm going to progress you now. Look at what you can do. And they say, oh, big deal, I'm still not walking. Yep, but you could have only done 3 of those last week, and now you're up to 6. And then trying to point out barriers to them that the patients have already identified, and then trying to break down the wall so that they don't see them as barriers anymore. A lot of people say, I have absolutely no time to do my exercises. And you say, okay, all right, let's pick the one most important one out of these 3 that I gave you. Or let me show you some ways that you can do this while you're standing up. Or, oh, you're walking to the metro every day. Let's put your lunges in while you're actually walking to the metro. Okay? So trying to be creative to get them to keep themselves engaged. Looking at lack of progress could be your fault. You chose the wrong activity. You could not have taught them appropriately. The person could misunderstand the instructions, so they're only doing it once a day and you needed them to do it once an hour. All right, so that's a communication thing. The patient may not do the exercises at all. How you can tell is you should be constantly reassessing them. So each time they come in, you're looking to see if they're following the pattern, because you're the expert. You know when they should be improving from a tissue healing perspective. You know that you're giving them exercises. So theoretically, if they're doing them, they should be better by now. So knowing, how long does it take to develop strength? How long does it take to develop, improvements in motor control or improvements in range of motion? You must continually modify the exercises. I see patients all the time. They have the same home exercise program for 12 weeks. But they're getting better because they're being progressed in the clinic. But a lot of the work happens at home. So make sure you progress their exercise program. So we're going to look at this exercise when we get in class together. So just be sure to check it out. And I will see you on Monday.